Okay, and we're going to start then. Well, good morning. Uh, so in general, the specimen identification is going to confirm the identity of the patient, as you well know. We have these barcodes that automatically can scan the identification of the specimens. Sometimes we want to double check in case we don't use the bar. And the most important thing, as always mentioned to everybody when we are doing a sign outs, is the clinical information. One of the things that I always emphasize is that we are physicians, that we use images for the purposes of our specialty, similar to a radiologist, that they are physicians and they use images to complement the diagnosis. So if we don't have the clinical background or the clinical history, we are not really going to do pathology. Pathology implies that you know what is going on with the patient. We are not image diagnosticians. We are physicians doing diagnosis with images, and those final diagnoses are going to be in correlation with the clinical history. Many times we may find very similar findings under the microscope, and then based on the clinical correlation, we can make completely different diagnoses. So remember, that is always a must. And in my practice, I really consider that it's not appropriate to sign out a pathology report that is says in the clinical history unknown or not provided. If it's not provided, we have the obligations to look into EPIC or any other source for what is the reason for the specimen that you're going to examine. And so just remember, I know that many colleagues sign out cases with no clinical history, and I respect that. But my personal recommendation is that you never, never, never sign out a case without clinical history. Thank you. So the next part is going to be the gross description. In case that we are dealing with small specimens, we are going to basically describe if it is a biopsy, the length. In case of transurethral resection of bladder tumors, for example, I always want to emphasize, as I will mention later, that the weight of the specimen is more important than the measurement. And in those cases, we need to even document in the final diagnosis the weight of the total specimens, especially in transurethral resections, and also either for prostate or for bladder. Once the description is done based on the CIP guidelines, then we have to do the submission of the blocks, as you well know, and with a very clear identification of the slide key. So we're going to start with the gross examination of the kidneys. And this is basically the images that are presented in the CAP manual for the grossing examination of kidneys and the different locations and degrees of invasions that these tumors may have. And it is extremely important to document that in the gross examination. Many times, there are some features that are not evident in the gross inspection that we are going to confirm or find or discover when we do the microscopic examination. But anyway, sometimes, for example, the tumor is too close to the capsule, and if the capsule is not completely smooth, indicating that there is no invasion through the capsule, and if you find some kind of irregularities, then it's important to mention that. And even though there is not definitive evidence of invasion of the capsule, you may say suspicious, but not definitive for invasion of the capsule. So many times I have to correct some reports that, for example, they mentioned the tumor is going through the capsule, but when we do the microscopic examination, there is no such an invasion of the capsule. So I don't want to have discrepancy between what is said in the cross examination and the microscopic description. So I need to edit in those cases that in the gross examination, this kind of a more definitive statements and make them kind of with the word suggestive or something like that. Because if you say that there's invasions through the capsule and the microscopic description doesn't show it, then the clinician is going to get confused because they say, well, how come you in the gross you're saying that it's the invasion, but in the microscopic there is no invasion. So we need to correlate or at least conciliate in some way. And many times, if there is some doubt, let's use some kind of a more intermediate words like suggestive. It appears like, but it's not definitive or something like that. Okay, so that is going to be an important feature in your examination. And in regards to general features, of course, the weight of the specimens and the measurement of the specimen is the most important thing. And then in the case of the kidneys, we want to document very well before we touch anything or we do any inking, if the renal vein is involved and if the tumor is present in the margins, and if there is some additional tumor thrombus that is being submitted in the bucket. And then do longitudinally cut open of the renal vein and continue cutting the vein branches within the kidney to search for intraluminal tumor. Because remember, all this examination and all this sampling is going to correlate later on with the stage of the tumor. So you need to always have in context the how relevant is going to be the examination of the gross specimen late in correlation with the posterior microscopic examination. Now, if the tumor is protruding through the renal vein margin, it's important to make the difference. If just the tumor is loose with no invasion of the vein of the wall, or if in the margin, or if this thrombus is really invading the vein wall, and also measure the distance of the tumor to the renal vein margin as well, in case that it is not present in the vein margin. In case of the partial nephrectomies, it's important to examine the parenchymal resection of the specimen. Many times the tumor appears to be at the margin, and that is an important consideration for residual tumors that the patient may present. Sometimes the surgeons are going to submit margins in separate containers, parenchymal margin or even superficial or capsular margins, when they want to be sure that there is no tumor left over in those areas. However, the main specimen may present positive margins. So when we make the correlation at the end, remember that the final margins are going to be most likely represented by those additional specimens that are being submitted and not necessarily on the first specimen. However, when you do the evaluation of the specimen, in particular the main specimen, in this case of, for example, partial nephrectomy, you need to mention if the margin is involved. So it doesn't matter if later on we have additional margins. For the overall evaluation of the case, yeah, of course, we are going to consider those additional margins, but for the evaluation of the specific specimen, we need to mention if the margin is positive or not. And if you want, you can even put in a comment, or just when you made the assessment of the margins, to put a comment that it says, refer for final margins to specimens A, B, C, or whatever, that they're different from the main specimen of the nephrectomy or the partial nephrectomy. So the inking and the cutting, etc., all these are going to be part of your procedure, and we are going to do in the radical nephrectomy a more detailed description. And the taking of pictures here in the partial nephrectomy, I forgot to mention also that you need to take pictures. And these pictures are very important, especially for the pathologist who is signing, for the faculty who is signing out, because we are not usually at the gross table. We need to document more specifically and correlate whatever has been described by the person doing the grossing, and we in correlation with the microscopic description. So it's very important, that documentation, and I'm always going to be very picky about that. And if I don't find a picture in a case, either because COPATH didn't register, sometimes the cross-examination says that pictures were taken, but it's not present in the file. So we need to request that that picture be included. And if it is not mentioned, the picture being taken and not pictures in the report, then we want to ask you to go back to the bucket and take some pictures, because that is an extremely important documentation nowadays. So we are going to make the description of the tumor with different parameters, as you can see here. I'm not going to go into every single detail because we're not going to have the time, but all this is basically taken from the CAP protocol, that you should be very, very aware of all these details. Now, just to remind you, the different stages that we are going to evaluate depending on the location of the tumor. And this is something that it needs to be placed in consideration when you do the grossing. As I mentioned before, the grossing is going to basically dictate the way that we are going to interpret the final microscopic description. So the locations of these tumors, if they are well confined into the kidney, or there is invasion, directly invasion of the adrenal gland, or if it is a metastatic invasion, that it, for example, the tumor is in the lower pole, but the adrenal gland has a tumor, that is a metastasis, that it should be considered an M1 and not a PT4, in contrast to a direct invasion from the tumor into the gland. And then if we find the invasion of the fat, of course, there's going to be especially landmark for the staging. And just to for your knowledge, I consider that invasion of the renal sinus fat is even more dangerous as compared with invasion of the perirenal fat, because even though they are considered as PT3A, the invasion of the sinus fat is 15 times more aggressive as compared with invasion of the perirenal fat. So very, very important to do a very good assessment and sampling of the sinus fat, especially the tumor, even if it is pushing or appears to be pushing, just to do a good sampling, because that is going to change the approach of the staging of this patient. Anyway, so these are some pictures taken from your collection, very good pictures taken for science residents. Sometimes they take only the external surface, and that is something that probably they heard about. We need to take pictures, but the external surface, I think that is good to have it. But the most important documentation is going to be in the cross sections of the specimen, from end to end, as you can see here, where we can see even the renal parenchyma, that it was well sampled, that is very good delineation of the borders, etc., that can give us an idea that that tumor is well circumscribed. But sometimes we may find invasion in the slice, but and if we don't have and a good documentation of the pictures, then it's going to be difficult to make the correlation. And the other way around, sometimes we don't find any invasion, and then in the picture we see that the tumor is really perforating or is at the margin. So that's why I consider that these images are very important. And here we have in the kidney, in whole radical nephrectomies, the external aspect of a tumor. Not all the tumors are going to have an external appearance, but if you find it, that in this case, the external picture is going to be very important, as well as the cross section of the tumor. And this other case, remember always to cut the kidneys from the border that is opposite to the hilar border, because that will allow us to keep the integrity of any kind of tumor that is present at the level of the renal sinus or in the pelvis, and we can make a better correlation. So according to the protocols, you can section the kidney with this kind of a bread loaf either way. But I think that based on our experience, I would prefer always to do this kind of sectioning, keeping contact of the borders here at the level of the hilum. And you can see also that the ureter has been as well dissected. Here is another case in which a suspicious area for probably perirenal invasion of the fat is present. This tumor is protruding. So the resident was well aware that this could be a significant element and took a good close-up of the image of this tumor just to be able to have a better correlation. As you can see, when you see these pictures in whole magnitude on the screen, they are going to be more reliable and with more definition as compared with a naked eye examination that is going to be always limited by our eyes. The photography has the capacity that to give you a kind of a middle of the road between the gross examination and the histological magnification. So as I mentioned before, this is a very important feature or requirement in the gross examination nowadays to have a good registration of the pictures of these lesions. And then again, something that I didn't mention before, but it's always do a very good description of the aspect of the cut surface of the specimen, because as you can see in this one, it's very variegated with hemorrhage and different areas, different colors. And as compared with other areas, for example, in this case is a typical chromophobe, very uniform appearance of the parenchyma that is completely different. In this particular case, there is a tumor that appears to be in the pelvis, that it has some kind of a papillary features. And this tumor is completely different to the previous ones with all these irregular appearance and colors and cystic appearance, etc. Also document the tumor is invading the renal vein, and its particular one, there is a big thrombus that is being projected from the tumor into the vein. Here is the pelvis, and this is the surface of the most external surface, the perirenal fat. So in every report in the area of the gross examination, just immediately after the description of that main specimen, the radical nephrectomy or partial nephrectomy, you need to include this outline that is taken also from the CAP template. But don't put it in the comments, don't put it in the microscopic description, put it where it belongs, in the gross area, just immediately after the specimen description. And then in cases that we have just tumors in the renal pelvis, remember that the location of the tumor and the depth of invasion is extremely important for the staging. And we can go from the very surface as a TA, a T1 if it is the submucosa, or a T2 if the muscularis propria is involved, or a T3 if the renal parenchyma is being involved. Here are some examples. These tumors are very nicely located in the pelvis and kind of forming this kind of molding, and the tumor has been kind of lifted up, showing the area of insertion and also the areas of growth within the pelvis, and the corresponding sections need to be done in the proper way as well. Here is another tumor that is also very papillary, present in the pelvis, but it appears to go into the fat. So this tumor went beyond the muscle invasion and now is involving the perirenal fat or the sinus fat, and good samples of this area needs to be taken. And all these samples, specific samples of the tumor, are going to depend on the location. And never forget the ureter. I've seen probably 3 or 4 cases already of kidneys that are completely normal. And the description is very good about the kidney normal, and they took representative samples, there is no tumor, etc. And then next case. And then I see that the specimen had a 10 centimeters or a 20 centimeter ureter. And then the question comes about, and that's why it's so important to know the clinical history. Why did they remove that damn kidney? So it's just not only just to check the kidney and the kidney is okay, take a representative section, but there is a reason for why the nephrectomy was taken. So let's look at ureter. And in this particular case, it's a ureter that is very thick and very edematous, and with some irregularities in the way that requires to have a very special dissection, etc., and description, and also the corresponding pictures. And in these cases that I mentioned, 3 or 4 cases, that there is a very good description of the kidney, and the ureter is only sampled at the margin, and there is almost no description of the whole ureter. The ureter has to be dissected longitudinally to be able to explore the whole surface. In all those cases, there was either a tumor or a narrowing of the ureter because of vascular malformation, etc., that had been conditioning these procedures. So remember that the ureter is even a different specimen. And when you do, for example, a nephrectomy with ureterectomy, you need to consider there are 2 specimens there, even for purposes of charging. In the CPT code, there should be 2 charges. But anyway, for the purposes of diagnosis, you had to have kidney and ureter, left radical nephrectomy with ureterectomy. And if you even want to document that it's a real ureterectomy, you can put in parentheses the length of the ureter, 10 or 20 centimeters, to just show whoever is reading the report that it was a real dissection of the ureter that usually is not present in other kind of radical nephrectomy. So the removal of a significant section of the specimen means something. And then you need to document that and put an additional item. In addition to the kidney diagnosis, you need to put the diagnosis of the ureter as well. So the gross summary for the ureteropelvic is also similar. You need to identify the most important features and put this outline just immediately after the description, the gross description of that particular specimen. So let's go to the urinary bladder now. And this, we're going to start with frozen sections in this case. Any other tumor specimen can be also subjected to frozen section, but usually the urinary bladder tumors are more common assessed. The surgeon wants to know if the ureteral margins or the uretral margins are free of tumor. And then we have a increased number of these kind of specimens, and it's very important to have this evaluation. And sometimes it's kind of tricky especially when we want to assess CIS in a frozen section. So and that is one of the items that you need to be considering here. As I said, freezing artifact may induce atypical features in the urothelium that later on in the permanent section is not present. And remember also to have your internal rulers. The best rulers that you can find are the red cells that are 7 microns in diameter and similar size also for lymphocytes, especially for the size of the nucleus. If you find a nucleus in a urothelium that is well sectioned, there is no distortion, there is no cautery artifact, there is not any other artifact, and you can see well the tumor, the size of the nucleus in the urothelium. And if it is more than 2 times the size of a lymphocyte, then you start making the possibility that this is not just reactive, but it could be like carcinoma in situ. And also the difference in the morphology of the nuclei. When you don't find the nuclei are not identical all along, that each nucleus is completely different to the next one, that is also another important feature. So, and remember that some tumors, like especially the plasmacytoid pattern of these bladder tumors, they may mimic inflammatory cells, especially plasmocytes, and they need to be considered. And always be very kind with the surgeon when you report your values, because if you are not sure, you cannot make a specific diagnosis. You just make the comments of suspicious but not definitive, and send for permanent section final diagnosis or something like that, or ask for more tissue, or make more levels. And that's the most important ways to behave in these cases. Then we go to the grossing of the urinary bladder specimens. In the case of the transurethral resection, as I mentioned before, and I have highlighted because it is extremely important, the weight. I mentioned it to the residents that a tumor from the bladder can come either in different ways. You can just put it on the plate or on the table in form of a muffin or in form of a tortilla, and they are going to have completely different measurements. So the measurement of the tumor itself, those gross measurements basically don't have any meaning. The weight is extremely more important because any shape of the whole specimen, the conglomerate of all those fragments, is more important to know the weight, the amount, than the measurement. If you want to measure, you can measure the largest pieces that are most important, and you can put them in separate cassettes that may represent sampling of the muscular propria or better samples for assessments under a microscope. And then try to submit the tumor entirely, even if there are big tumors. Unfortunately, we have to spend more time. I've seen cases that we have 30, 40, or 50 grams of tumors. And if you want to be conservative, the most important things in the diagnosis, are the depth of invasion. So if you have a very large tumor and you don't submit it entirely, and you don't find the most important features, for example, muscular invasion or invasion muscularis propria, you see that the specimen is invading the lamina propria, but not the deeper levels, then in that case, you need to request the submission of more samples to be sure. But if in the few samples that you examine that are representative, you find all the features for diagnosis, like invasion, the papillary transformation, and involvement of the muscularis propria, then you have all the elements that are necessary for the evaluation of the specimen, and you don't need to submit more samples. So always to consider that. And then when we go into the cystectomy, we just have do the inking. And remember always, when you do inking of any kind of a specimen, you have to do it in the way that it comes to the table in the bucket. You never remove any piece of tissue before you ink it. You have to do the inking first, and then you remove the prostate, for example, or any other piece that you need to remove for the dissection. And then we open the specimens through a Y shape through anterior wall. Now, in the fixation, the most important thing in the fixation of these bladder specimens is that if you put the bladder just like it is in the bucket, the outside is going to be very nicely fixed, but the inside may be rotten after 24, 48 hours because the formalin is not going to go through. So there are two ways that you can use. You can put either a Foley catheter and perfuse the inside of the bladder with formalin, so you are sure that the inside is being fixed, or the most easiest way is just to do the section, the Y shaped section, put it on a cork or in a board, and then fix it in that way, so where in and out can be fixed properly. So you have to document all the features that you can find in this specimen, in taking care of the margins, any other kind of soft tissue that is attached, especially if there are some regional lymph nodes, and then the any kind of segments of ureter and urethra that may also have cancer. Remember that urinary cancer usually is multifocal, and patients who have cancer in the bladder, they may have also cancer in the urethra, a completely different focus, not necessarily invasion from the primary tumor, and also may have cancer in the ureters at different levels. So it's extremely important to do that kind of multi sampling in these specimens. This is just another of your cartoons that you have in your protocols, and just remember all the sampling that you should take from the tumor, especially, and then sampling randomly from all the other areas, representative samples from the different, the trigone, the dome, the ureters, prostate, etc., etc. And these are the sections to be submitted, just basically an outline as you have in your CAP protocol as well. And then remember that when you do the gross summary, it's very similar to the previous cases, that you have to outline the procedures, the is there a cystectomy or radical cystoprostatectomy. Here, we would need to, in other cases of females, many times the bladder comes together with the uterus and ovaries on part of the vagina. So we need to specify that in the other line. And the lymph node identification is extremely important as well. As you know, through the years, urologists have found that the more lymph nodes that are being taken at the time of cystectomy, it correlates very well with the survival of the patients. So at the beginning, there were groups that were taking 6 lymph nodes, and then later on, someone decided to go to 12 nodes, and then when they studied the survival after 5 years, they noticed that the 12 lymph node dissection was better survival in those patients when, as compared with the patients who had only 6 lymph nodes dissection. So now they are going to 25 lymph nodes, as was here reported in 2009. And then through the years, we've been trying to improve this dissection of lymph nodes. And it's not surprising that a surgeon comes back or calls you when you find that in the lymph node dissection, there are only 10 lymph nodes being identified. And said, but I removed more. There was a lot of fat there. Yeah, well, there's a lot of fat, but there was no lymph node. Or probably the resident was not meticulous enough to really look for the lymph nodes. And in those cases, we just had to go back to the bucket and start looking for more lymph nodes to fulfill these requirements. So these patients are treated properly, and the documentation that good lymph node dissection has been done. Otherwise, the surgeon is the one who's to be responsible for that. And well, this is again a kind of a identification of the different stages. I'm not going to spend more time on that, and just show you some pictures of very nice images taken from specimens. And this is a very interesting bladder that was very rigid, and then when it was open anteriorly, it didn't open very well. So here the resident just used her hands and just to show the tumor and get a nice close-up to see this papillary formation. And also other specimens in which you can see by translucence some alteration that could be invasion of by tumor, and then the corresponding internal images. This is it is ideal that you can take the pictures before you fix the specimen, where the conditions of the lesions are very clearly stated here, as you can see in this picture. And don't forget to take pictures of the sections of the tumor, because here you can see the perivesical fat, and here the tumor on the surface of the mucosa, and here this area that looks like invasion of the tumor. And this is extremely important, that in addition to the overall picture of the tumor, you go and take also pictures of the cross-section, as is illustrated in this one here. Then we continue with another important element in this pathology, the penis. And you know that the most important pathology is going to be a squamous cell carcinoma conditioned by HPV virus. And this is just some reminders of the different levels that we need to be able to identify in this specimen when we do cross sections, to be able to do first a good identification from the gross point of view of which area you are talking about, either if it is area of the corpus spongosus, or the corpora cavernosa, or the albuginia, and correlate the presence of the tumor with those structures that are the most important landmarks in this organ. This is just another section also taken from the CAP, in which you have the glans penis and the most important section that you can make longitudinally, but to identify the urethra and any tumor that may be arising in the surface if it is involving the corpus cavernosum or the urethra. The invasion of tumors that are arising on the surface in the skin and going to the urethra are the highest grades that you can find in these dissections. This is another dissection also just to illustrate, as I mentioned before. This is a specimen. This is a whole penectomy that was also taken because of the presence of a tumor here. There is a fistula that was produced with the urethra that was also documented. This is the way that it was in the patient. It was not an artifact. And then here we have the longitudinal dissection. You can see this tumor that it has created this fistula. It has also involvement of the glans penis, and most likely with no evidence in the areas more proximal in the surgical margins. So in a good way, the resident also took close-up pictures, and this is a very important that you always have that kind of a initiative that when you see areas of interest, not only to take the general picture, but also get some close-up that allows you to do a better examination of the gross specimen. And this is another specimen that was also cut very nicely longitudinally, showing the extension of the tumor that in this case apparently started at the level of the urethra and is going protruding next to the surface as well. And this is just a partial penectomy. This is just the glans penis, as you can see, also to illustrate the presence of a tumor that is close to the urethra, and you can see the areas of involvement from which the most important sections have to be taken. And then we have the testicle, and we have another basic illustration from your CAP protocol that shows the different possibilities of the invasion of this tumor. Tumor A, for example, is already invading the not only the tunica albuginea, but it's also outside invading the tumor the tunica vaginalis. Remember, the vaginalis is just kind of a single cell. It's just a mesothelial kind of a lining, and we are going to see it better in the microscopic description or examination, but sometimes you can see the irregularities of the surface of the testicle when there is invasion. And also take care of the tumor when it's close to the retitestis or the epididymis, and also in the spermatic cord that are going to increase the possibilities for dissemination as well, or even in the fat tissue. This is a specimen here. It was taken just external view, and then the internal view of the section where you see this well-defined tumor with this kind of it's called, the classical definition is just kind of a fish flesh appearance. We always compare things with food in pathology, but then someone compared the appearance of these tumors with the flesh of the fish, and you can see this very well circumscribed, and this is typical of a seminoma. Here we have another tumor, also most likely a seminoma, very well circumscribed, and the relationship with the other structure that needs to be documented in the gross examination. Here we have another case where the surface of the cut section is more irregular. This was a mixed germ cell tumor with different components, embryonal carcinoma, seminoma and yolk cell tumor, that it was kind of too close for comfort, we say. And here in this area, there was a possible invasion of the tunica albuginea, but likely not of the vaginalis. So in this case, if the gross examination is not very conclusive, you can say suspicious but not definitive, and then we can confirm it with the microscopic description. So remember, if you really are not sure of the invasion of structures, just put something like suggestive or suspicious, but try not to make a very overt statement that needs to be corrected later on, because in the microscopic description, we don't find that kind of invasion. And finally, we have this other case that is even more bizarre, with a very irregular appearance, a very large tumor, as you can see here, in more than probably 20 centimeters, larger than the size of the ruler. With all this is basically a tumor, but with a lot of fibrin. So there is a hemorrhage. It was a significant amount of hemorrhage, and then this was organized, and it's basically a lot of fibrin, and the tumor was in the midst. And this is another typical appearance of what is called, this is a teratoma, with all these cystic appearances that are typical, and also replacing basically almost 100% of the testicular parenchyma, with some cystic formations here in the epididymis. And finally, we have the prostate. And for the prostate, the summary is going to be done by the prostate laboratory, as you know. And unfortunately, the residents don't have hands-on these specimens, because in part are also done for research purposes. But I want to show you this presentation that we did. This is just a 3 minutes, in which Nancy Doscom, she already retired, is showing you the aspect of the prostate. And the first thing that she's going to do is to ink the whole specimen with India ink that is going to be blue in the left half of the prostate, and then green in the right side, trying to separate these two colors. But on top of that, because those inks are not really very sticky to tissues after, we ink them completely with black ink, because the black ink is more stable, but still we have the green and the blue underneath. And then we fix it with acetic acid, as you know, and at that moment we remove the seminal vesicles, as you can see there, and then we go to the proper measurement of the prostate itself without the seminal vesicles, both for the weight and for the volume. And for the volume, we calculated by displacement of water in a cylinder with water, and by the amount of cubic centimeters that are going to be displaced, we have a very good measurement of the volume. And then we are going to section the prostate from apex. Here in this moment, she's cutting the apical portion, and the last part of the section, she does it with scissors. So to avoid that the crinkling of the curved cut surface and produce some alterations of the surgical margins. So she continues after sectioning all the prostate from apex to base, doing sections of the seminal vesicles, as you can see there in the upper left, that she has all those sections that she's aligning in consecutive order, and then they are going to be placed in the corresponding cassettes, and also little bags that are made for the larger specimens. So very nice dissection here. And we, the ones who already are familiar with those sections, you remember that they are different levels. The whole prostatectomy submission, in which the smaller samples are placed in the conventional cassettes, but the larger sections are going to be embedded in these crinoline bags because the cassettes are not big enough. And this is the kind of a material that is used for the veil of the brides for wedding. And then we have the formalin, and the rest of the process is just as a conventional one. So this is a series of both YouTube videos with very detailed demonstrations of dissectioning of the urinary bladder specimens. For the cystoprostatectomy is the one that I just showed you, but the one that I show you is just a brief version with 3 minutes, but the other one is a little bit longer that we also have online. And then review this particular gross examination and sample surgical specimens for urinary bladder. This is a nice article that is relatively updated. It's just 10 years ago, but basically everything that is written there applies to what we usually do. So if you have any questions, I will stop here the presentation, the PowerPoint, and I'll be happy to answer any question you have. Thank you.